Hi, this is Mike Blevernick with the Academy, and I'd like to welcome you to today's webinar, Leveraging Patient Price Estimation Tools, a case in enhancing point-of-service collections and the patient experience. Just a little bit of housekeeping before we start. If you do have any issues with the WebEx or hearing the audio or anything like that, go ahead, give us a call at 888-700-5223 for any assistance we can provide in helping to mitigate those issues. Also, if you have any questions today during the webinar, feel free to type them in the Q&A space on the right side of your screen, which you should see in WebEx. We're going to have some opportunities at the end of the conference today to take some of your questions around price estimation. So again, please type those in. We'll take those questions at the end with our two speakers today. Without further ado, I would like to introduce you to our speakers today and hand it off to them. We have Jerry Pack, who is the Director of Revenue Solutions at Baptist Health in Alabama, and has over 30 years of experience in healthcare, has been with Baptist for several years in that role of System Director of Revenue Solutions. And from PMMC, we have Terry McManus, who has over 24 years of experience in business and technical analysis, specializing in product management. And Terry will be our first speaker today and kind of kick this off by giving all of us an overview of the industry and some of the challenges out there today in terms of health plans and things like that. So, Terry, please go ahead.
Okay, thank you very much, and good afternoon, everyone. First of all, thank you for your thoughtful introduction. It's certainly a pleasure to have the opportunity to participate in one of HBI's Solution Academy webinars. With today is also Greg Kay. He's a Senior VP here at PMMC, and he will also be available for questions as well. And I would like to thank Jerry Pack for her leadership during the implementation for several applications. Okay. If you want to move to the next slide, thank you very much. As more employers and payers look to reduce expenses by shifting costs to consumers, high-deductible health plan enrollment continues to grow. And into the recent media coverage, like the prominent Time article on hospital charges, transparency has become a hot-button issue in the healthcare industry. Proactive financial communication is still a fairly new process. Jerry engaging in proactive role with her team. Her willingness to extend her knowledge to the others was a critical success factor. And it didn't surprise me when Jerry agreed to share Baptist Health's experience with this group. So Jerry, I want to thank you again for all your time and leadership. Now noted on the slide, the healthcare industry has been under the microscope with greater and greater demands for pricing transparency. As of today, patients will want to know how much various healthcare services are going to cost. If in an urgent situation, such as an accident or a heart attack, obviously cost doesn't really matter. You just want to be taken care of. But if a patient is having a non-emergent urgent procedure, such as a diagnostic service, a colonoscopy, or maybe an MRI, they'll be likely and inclined to shop. Noted on the graph, the desire to shop is being driven by the fact that patients' out-of-pocket responsibility is rapidly growing. Just over the past 8 years, the patient's responsibility has grown by over $1,000. In 2006, the average deductible was $775. By 2014, that amount had more than doubled to nearly $1,800. Employers and payers have been shifting more of the cost or financial responsibility to the consumer through high-deductible health plans. The trend will continue as I hear of more and more people with $2,500 plus deductibles and family plans with between $500 and $3,500 deductibles. The American Hospital Association reported this week that for general medical and surgical hospitals, their actual or expected reimbursement received for service across a full range of payer types was up by 0.5% from May 2014 to May 2015. So the trend is flat overall revenue growth, while a large portion of the collection of the revenue is being shifted to the patient. They will be everly increasingly price shopping for healthcare services and are seeking transparency in regards to healthcare costs. become more informed about the workings of hospital finances if we communicate it to them. If not, bad debt will likely arise in the future. Even as self-population has decreased with the rollout of the Affordable Care Act, many individuals still have high deductible plans. So that estimating costs prior to services allow the patients to understand their financial responsibility and make decisions about those services. This is where Baptist was last year. Jerry, can you give us some background on Baptist Health?
I'd be happy to, and thank the Academy and PMMC for allowing me to share Baptist experience here. So, Baptist Health is in Montgomery, Alabama. We have a picture of our largest facility. We have 3 inpatient facilities, Southeast and Principal. Also, as a system, we also have multiple imaging centers, cancer center, ambulatory surgery center, just a full range of services. And we serve not only Montgomery, but Central Alabama, a rather broad population. So with that said, we wanted to do the very best for every patient. So if you look at our next slide, you can see what our challenges were. We were not able to provide an estimate front to a patient prior to their having services. Well, that was a great patient dissatisfier. It obviously led to increased bad debt, their account resolution, obviously in the end, denials and underpayments. But Baptist Health had a vision. Price transparency was the heart of that vision, and the vision had to be shared by our team here. And we have a grand team, but that team is our administrators from a corporate level through our facility at that level to our central business office and then to patient access. Our team came together to make that vision of price transparency a reality, and our partner in helping us achieve that or enabling us to was PMMC. So that's why I'm happy to talk with you today to tell you about our journey. Our goal with vision was to be able to help the staff actively communicate the patient's financial responsibility so they could better budget for their care or become engaged in discounts and assistance proactively, because at the same time we were vetting vendors to provide a price estimation tool. We were revamping our whole charity and discount processes at Baptist, so that all of that came together with the implementation of our Estimator Pro. So our vision was twofold: providing price transparency, but also robust financial assistance to patients who are in need. So, to move on, we went through a 2-year vendor selection process. Truthful, we vetted 5 different vendors before we selected PMMC as our vendor of choice for our estimation tool. There were some key elements or requirements that led us to choose PMMC. First and foremost was the PMMC's ability and willingness to integrate with our current eligibility structure, which we have through our ClearWave kiosk application. So also, PMMC certainly has a proven track record in generating accurate estimates based on actual payer contracts. So, recognizing those qualities and capabilities with PMMC, we decided to form a strategic partnership with them. So to do that, our first step was to set up all of our data, and this is where the team at Baptist came into play. Our central business office and our IT partners here uploaded all of our 835 and 37 data retroactively for a year, and set that up then to upload daily into Contract Pro, which is what I call the bedrock of PMMC. At the same time, that team uploaded all of Baptist payer contracts in Contract Pro and CDM. So that Contract Pro was built out with all of this Baptist-specific data loaded in it. So we have a triangulation of data available to produce an estimate. So once Contract Pro was built, that capability was moved into Estimator Pro, which is where we could then start issuing our estimates frontline. Slides should take us further into this. So this gives you an idea of, to flesh this out a bit. So an estimate is a combination of payer contact data, historical data, eligibility data, that's from Clearwave, CM, and then, of course, the CPTs and the ICD-9 codes. All of that triangulation comes together within Estimator Pro, which allows our frontline staff to generate an estimate from Estimator Pro. And then the registrars can educate the patient frontline. The professional estimates, if an example, if it is an estimate for a patient who is a payer, the estimate will return the patient's financial responsibility, but broken out into copay, deductible, co-insurance, all based on the eligibility data generated through Clearwave. So for the self-pay patient, we have set the tool up, the estimation tool, to automatically apply a 40% discount for those patients who are identified as self-pay. And those who express concerns about their financial situation can be referred to financial counseling prior to services being provided. I have been more focused on ePro, but I have to give credit to Contract Pro, which I call the bedrock for ePro, but it's also implemented in our CBO, and it is used by the CBO staff to identify contractual variances and communicating those to payers. So it is a very versatile and very important tool in our implementation. So, move on. So we tell you a little bit about the implementation. We kicked off in June of 2014 with a meeting. PMMC folks came down and met with our whole team and all the stakeholders, from administrators to the team of CBO and patient access and IT. We developed our project plan together. We set up project calls, action plans, items to be followed up. I will say that I commend PMMC for their excellent project management of our engagement. Also, the great team effort from Baptist. Those two elements coming together created the success that we have achieved. In addition, PMMC has sent trainers, 4 in total, to Baptist to conduct sessions for our staff on both Estimator Pro and Contract Pro. We rolled out Contract Pro on February 1st of this year, so we're not in our infancy, but we're sort of in the toddler stage with Estimator Pro. But we are still providing education for our staff, and that is produced collaboratively with MMC, with screen prints and directions. We also have had one upgrade to PMMC's Estimator Pro in May, and that upgrade included several different elements of functionality, some of which we had suggested to PMC, and they incorporated it into the application. We made it, we thought, more user-friendly and more flexible for us, but it was important to us that PMMC listened to our suggestions and did, through their internal departments, actually make our wishes a reality in their system. And the next slide is just a high level that typifies how our patients appear in our process at our intake points. As I mentioned, we have ClearWave kiosk deployed at all of our intake sites. So about 90% of our patients are registered or are taken into the facility at the point of service through the kiosk. And so here's a little diagram that shows how the patient presents, identifies themselves at the kiosk by scanning their ID. Once they're identified, the patient can scan their insurance card, front and back. The kiosk automatically sends an eligibility query directly to the payer's website. From that query, an eligibility response is returned and loaded into Estimator Pro. The patient arrives at the registration desk. That registration specialist can produce that estimate very easily by entering either the name or the CPT or DRG of the service that patient is anticipating having, and then the eligibility information flows into the estimate, and the estimate can be produced. So it's a pretty seamless process, and it worked very well, and the more we use it, the better we get at using it. That takes us to some of our results. Our pre-registration department volunteered to be the pilot department for Estimator Pro, and that piloted that from December of 2014 through January of 2015, and then we went live on February 1st of 2015. And at the end of February, we discovered that the Prince Department collected the most in point-of-service collections they ever had. So that was a great win-win, and I think a reward for the department for taking on the piloting of Estimator Pro. Obviously, that we anticipate certainly that this is going to reduce those bad debt write-offs downstream. But I mentioned earlier, with an implementation February 1st, we did June, we will see that bad debt reduction a bit further down the road, but I do anticipate it. The CBO has been delighted with, and I won't speak fully to this I've been more focused on, obviously, the Estimator Pro part, but they have been leveraging Contract Pro capabilities in their environment to identify payer contractual underpayments and actually being able to educate the payers on what they should have been paying us and recouping those underpayments. That is a very, very good thing. Right, and onward to lessons learned. First and foremost, it was important to vet all of those vendors. It was a long process, but that shopping around got us to the vendor who not only valued the vendors we already were very happy to work with, but could leverage technology we were already paying for into their application without our having to pay for that a second time, as some of the other vendors had wanted us to do. I think the training is important, and getting staff accustomed to this system, because this was a big leap for our registrars frontline. They are still learning, but I am very proud of them and proud of their leaders frontline who have worked with them every day to make them more comfortable with presenting those estimates. Service collections is a difficult thing for registrars to master with ease. This tool makes them much more comfortable in the process. So those price estimations have really three key variables. I'm going to call it triangulation. We have the accurate payer contractual allowable calculations. We have the accurate benefit information. We have the most appropriate anticipated service, selecting DRGs or codes based on historical data. So we come up with what is the most accurate estimate we could provide to that patient. And a few more lessons learned. It's important to continue open communication with our external business partners, which we have done. We've held weekly status calls with PMC to resolve any specific issues, to offer suggestions for changes or upgrades or modifications that will tailor Estimator Pro more to our needs at Baptist. PMMC has helped us to identify DRG codes for our inpatient self-pay services. They have worked with us to identify J codes so we can look those up for injections and infusions and give an estimate predicated on the J code or drug that's going to be given rather than just the fact that it's an injection or infusion. That may not sound big, but that's big stuff. Lots of big bucks, and patients deserve to know what their estimated cost will be for that. We've also done additional work with MMC on our certain services for outpatient variable lab rates, speech therapy rates. We are setting up special flat rates for some of those services for our self-pay patients. So, with that said, I think that's our story, but we certainly are open to taking questions.
Thank you for opening up the call today and going through, Jerry, some of your successes at Baptist. We have a few questions that have come in, and I can go ahead and ask those in sequence. And, Jerry, I think the first one is probably for you, from Connie, and her question was around if it would, in your opinion, be cost-effective for a 25-bed critical access hospital to use a kiosk system like what Clearwave has. You said you have 3 hospitals at Baptist, correct?
Yes, I have 3 acute facilities, but
And those
we
all
also have
fairly
imaging centers that are separate, and breast centers in our physician practices, and a cancer center.
And are the kiosks, or is that primarily at your larger facilities then?
All are. We rolled it out over 2 years. It's sort of roll under, I called it. So we started with the cancer center, a very high volume place, in 2011, and then throughout 2012 and 13, we rolled it from one facility to another, to our imaging centers, and then our physician practices. So also many of our neighborhood referring physicians, because of the efficiency of the system, have chosen to go with the Clearwave kiosk as well.
Okay. The next question is from Greg, and I think, Jerry, we can ask you first, but Tim, you may have some input on this too. Jerry, at Baptist, are you focusing your estimates on a specific set of services, for example, diagnostic imaging, or using that estimator for all services? And then you're using it for services. Have you had any issues related to the estimate not being exactly services that are ultimately provided by that doc?
That's a big one. Okay.
Questions in one, right? You gotta. Yeah.
Yeah. Let me see if I can sort through this. We are using it for all services. Not yet rolled it out. For instance, at the cancer center, we're working on doing that. We're using the estimator, though, to do infusions and injections at one of the facilities. But we have rolled it out across the board, facilities, imaging centers, etc. You know, sometimes it is challenging to get from a physician complete ordering information, shall I say. Sometimes it's back and forth in exactly what are you doing. But what I can tell you is that within Estimator Pro, you the bundle. So if I enter a CPT code, I pull that CPT code up and I can look it up. Outpatient procedures, I can look up either by CPT code or by an alpha by name. Estimator Pro will return those CPTs we have done, what we bill for them, what we bundled with them. So we had billed that CPT 127 times, but 56 of those times we billed it in a bundle with CPT code 3 and 4. In the other times we billed it with CPTs other than that. So we also now, with this upgrade that I mentioned, and Terry can maybe speak better to this than I, but we can now, when those bundles are presented and we know what our history is with that particular procedure or CPT, we can now remove CPTs or add CPTs to those bundles to make them match whatever that physician is ordering, if we get information from the physician.
And you make a great point in that, yes, we do profile the billing history of the facility, specific to each facility, and present the end user of the Estimator Pro tool with the most statistically likely occurrence or representation of that service being rendered. So if you have what information you have at the time of service, you would go with the statistically most likely, meaning it was presented, a CPT code on its own was done 100 times. It was in conjunction with another code 70 times. So you would want to go with the numbers. But if you do have additional information, like Jerry mentioned, we do have the ability, what we call, to edit or modify the claim, meaning you can add a code, remove a code, you can increment the units of that code, and all that stuff gets recalculated right there on the fly to ensure the patient's getting the most accurate estimate available.
And to add to that, Mary, we always must test an estimate. It is that, but it's pretty darn good
Question, and Jerry, he says this for you. Do your insurance companies provide enough information to get to that estimate, or, I mean, are some more effective than others?
PMC does, and our CBO, we uploaded our actual payer contracts. That was loaded into Contract Pro. And then Clearwave goes directly to the payer websites to bring back eligibility information. Yes, we are very accurate.
Thank you. Another question, and she asked before about kind of using the keys at a critical access facility. Her next question is, and maybe you can speak to this, how would MMC be valuable to a hospital that also has off-campus clinics, specialties, primary care, rural health care, to ensure patients get accurate estimates? Is that something you can speak to briefly?
Greg's going to speak to that one.
Yes, the system could be really helpful in any specific location. You would want to take a look at your volume that's coming through those particular centers. But we have seen both the estimation system as well as the Clearwave kiosk system being deployed in a variety of locations. The kiosk especially can be useful in patient check-in as the eligibility verification. I think you mentioned that you guys have more deployed Wave kiosks in a number of different points of entry across the Baptist Health System.
We have been implemented in our emergency department, but only as to identify the patient. Obviously, it's not a full registration. There's no insurance or anything because of EMTALA laws. But we love the capabilities of Clearwave in identifying patients. It's a very robust identification system. So we have it deployed at all manner of sites across the system.
A question from Andrea. Do you pre-register accounts before the patient comes in and uses the kiosk? And then
Yes, sir, we do. Obviously, we have walk-ins, but we do have a very robust pre-registration department, pre-registering all scheduled procedures, surgeries, ancillary. And they are the ones who piloted EstiPro. They do an excellent job of collecting in the pre-environment. The best I have seen, and I've been around a while, they do really a grand job. And the estimation tool, ePro, have just made them better because they now have the information they need to give the patient.
Thank you. From Jesse, are the estimates total charges, including professional fees, or are they strictly hospital technical charges?
Currently, they are hospital technical charges. We've gone to incorporating the physician charges estimates.
And Terry, and yes, Jerry, I'm sure we'll be moving toward that in the future, but the PMMC Estimator Pro does have the ability to provide the professional component to the estimate as well.
Jumping in and helping with that. He has a question. Have you found it easy and accurate to create surgical estimates for patients who are having multiple procedures done at the same time?
Well, that goes back to the fact that we can add to or reduce the bundles. Yes, because previously we had no way. You see, you can maybe come up on one procedure code. You can come up with a number, but when it comes to a surgical procedure, there is so much built into that you don't really, you can't enter that into sort of estimate tool, but by having the historical data for all of our surgical procedures, then yes, we can issue a really accurate estimate based on our historical billing practices, that particular procedure.
And this is Terry, just to chime into what Jerry said, and she's 100% correct, that you can, what we call, modify that claim and add an additional surgical procedure. And since that is calculated in real time against the contract management system, it takes into consideration all of the contract reimbursement terms for that payer. So if a multiple procedure discount is applicable, that would be considered and taken into the calculated expected reimbursement for the patient.
Okay, sure, thank you. Right, 5 more questions left, as long as we're okay proceeding with those. And again, thanks to all of you on the call for asking these questions. I think very good ones that get into some of the detail of this process and the system being used. Andrea's question is, how does the system know what EPT code to choose from when the patient is using the kiosk? And Jerry, did you say that's something the registrar actually kind of picks, or how does that CPT code selection process work?
No, the patient doesn't do this at the kiosk. The estimate is produced by the registrar, and the registrar is the one who picks the CPT and/or uses an alpha description to choose the right procedure.
Okay. The question is, do you have any type of reporting tools to show the difference between what is estimated and the actual patient responsibility ends up being, post-service during the bid process?
We haven't gotten there yet, but I think that's a very good idea. Let us move beyond our toddler stage, and then I'll do that.
Okay. The 40% kind of self-pay discount you have, Jerry, correct me if you have used any other type of upfront discounting for non-self patients as a way of kind of incentivizing them to pay up front. Do you have any type of he's probably talking obviously about a prompt pay discount or something like that. Do you use any type of that at the front end for your insured patients that owe a balance on that estimate?
We have not.
Okay. The question was around tracking the variance from the estimate and if it's impacted credits or refunds. Jerry, it sounds like you're kind of moving in that direction in the future. Have you seen or heard from your centralized business office? Have you been seeing any more credits than usual, or is that to be determined as well?
I think that's to be determined. As I said, we implemented February 1st, hopefully stabilizing it, and we can build out reporting tools. So let's plan to meet in 6 months or a year. How about that?
That sounds like a good plan. And then the last question we have is from Michelle, and she says, obviously the contract rate is one of the 3 keys to providing an accurate estimate. At Baptist, do you have contract rates for all services you provide or just for the highest volume procedures? And what do you provide to the patient in terms of an estimate if you don't have a contract rate for that service?
Well, I'll go back to contracts, which it varies by payer. In the inpatient per diem or there's outpatient. So again, it's exactly how that contract is constructed is how it is built into the system. And so if that procedure falls under, say, Blue Cross inpatient per diem, then that's how it calculates. Terry, maybe you can help me with this, or maybe I'm missing the point here.
I guess I'm reading the question is that I'm not sure if you have complex contracts or not. I mean, how are you guys negotiating your contracts with your payer? But we do profile all data, obviously I mentioned earlier, historically, and then we can use those billing patterns to calculate expected reimbursement, however those services are carved out on all the individual contracts. So hopefully we're answering the question that you've asked.
Okay.
And feel free to chime back in with a kind of a follow-up question if they aren't. Andrea had one follow-up question. She'd asked a few earlier. And she's asking if the accounts are pre-registered ahead of time, who in the kiosk where the benefits and the estimate is created. I assume your patients are getting pre-registered and then checking in via that kiosk, correct?
Correct. With the kiosk, we have our scheduling system that is interfaced to the kiosk. So if I'm scheduled, say, for an MRI, the skilled procedure is displayed on what I call the portal view at the kiosk, so that that intake site, wherever that MRI is going to go, or wherever that patient would go for the MRI, that's on their scheduled list for whatever date it is scheduled. In the meantime, registration working from queues from our scheduling system work those procedures and pre-register them, contact the patient, collect frequently from the patient in the environment. The patient arrives, they check in at the kiosk, they're identified by the kiosk, their insurance is verified, they present to the registrar, and the registrar produces the estimate.
Okay, I think that makes a lot of sense. So again, thanks to everyone for asking those questions. Thank you to all of you who attended the webinar today on leveraging patient price estimation tools. Also want to thank Jerry, Terry, and Greg for bringing their expertise and their story today. Again, really valuable information as we see those deductibles and those responsibilities rise. Once again, we at the Academy are available for any further questions on today's conference and materials. Call us at 888-700-5223. And I did not mention this during the conference, but we will send an email to all of you who attended today. We'll include the presentation you saw, and then obviously Jerry and Terry's contact information as well, in case you have further questions. So thanks again to all of you. We have another conference next week around ICD-10, but please join us next week and next month. Thank you very much.
Thank you. Goodbye.